Professor in the Interdepartmental Division of Critical Care Medicine in the Institute of Health Policy, Management and Evaluation at the University of Toronto, and a staff intensivist at the University Hospital Network / Mount Sinai Hospital. Dr. Fan received his undergraduate degree from the University of Toronto, his medical degree from the University of Western Ontario, and a PhD in clinical investigations from Johns Hopkins University. He is currently the medical director of the Extracorporeal Life Support Program at the Toronto General Hospital. Dr. Fan's research is focused on advanced life support for acute respiratory failure and patient outcomes from critical illness. It is my pleasure to introduce Dr. Fan today. Thank you so much for coming, and we look forward to hearing from you.
Great. Thank you so much for the invitation to speak. I'm just going to share my screen here. Let's see if it works. You guys can let me know if you see the right. Are you guys seeing the right screen, like the right presentation?
Yeah, it looks perfect. Thank you.
Awesome. Okay, so yeah, again, so thanks very much for the opportunity to speak. Happy to be here, if only virtually. Happy to see your questions. Hopefully I could see by chat or whatnot, but feel free to interrupt with any thoughts, feelings, or desires in the middle of the presentation, and throw some virtual tomatoes if you need to. And we'll see how it goes. So I'm going to speak about extracorporeal support for ARDS. What lessons did we learn from COVID-19? Here are my disclosures. I won't be speaking about any specific devices in my talk today. So we're talking about extracorporeal support for acute respiratory failure. And of course, in most instances, that means severe ARDS. And of course, I think this is ingrained in many of our collective memories over the course of the last 3 years of the pandemic, where we saw a huge deluge of patients with severe respiratory failure, many who required ECMO. But in 2023, this is a nice review from my colleague here across the street at our Mount Sinai Hospital, Lavina Munchik, sort of summarizing the 3 ways that we can connect patients to VV ECMO for severe respiratory failure in 2023. I would say amongst the more common methods are those seen in panel A and panel C. So panel A probably being the most common worldwide, using a 2 cannula setup. As you know, having blood drained from a large central vein. Here in this picture, the right femoral vein, it's sent by a centrifugal pump or an impeller system to an artificial lung where oxygen is added and CO2 is removed. And that arterialized blood is then returned, as the name suggests, back into a large central vein here in this picture, the right internal jugular vein. And then so you need a functioning heart, obviously, in the system, because it's only providing respiratory support, and the right heart pumps the blood through the pulmonary circulation, and then the left heart pumps that blood into the systemic circulation. On the right, we have this a more compact setup where you have a dual lumen bicable cannula. And in the inset, you could see that rather than having 2 cannulas do the job, you can have this done in a single cannula. And if anything, this is maybe a very large type of dialysis kind of catheter, where you can see in the cross section, there's a much larger drainage lumen than there is a reinfusion lumen. And as the name suggests, again, this is a bicable cannula. So the tip sits in the IVC. There's a proximal port in the SVC for drainage, this very large hole distally in the IVC for drainage. And the reinfusion port in the middle is directed typically under TE guidance towards the tricuspid valve. So the arterialized blood can go through the path of least resistance out into the right heart and pulmonary circulation, then on its way through the left heart and the systemic circulation. At least in my hospital, we typically reserve this kind of configuration for patients who are bridging to lung transplant, because one of the main advantages of this is that when you avoid groin cannulation, these patients can more readily perhaps participate in physical therapy, although I would say that, again, in 2023, groin cannulation is not a contraindication to physical therapy, at least in my unit. And we more sort of durably can get patients who are bridging to lung transplant awake, I would say, and especially in today's talk in COVID, I didn't see a lot of COVID-19 patients that we could wake up and get mobile during the pandemic on ECMO. And so again, because this system could be deployed with ultrasound guidance in almost any sort of circumstance, this is sort of our usual setup for patients with severe ARDS. In the middle, you see this approach where you cannulate both femoral veins, which again, because of where they sit, there could be some more issues with recirculation. This is actually a reasonably popular method of cannulation in certain centers in Australia. The Alfred Hospital in Melbourne, for instance, prefers this method as well. Part of it may be related to the fact that many of their cannulations are done by intensivists. And so again, this is an all percutaneous ultrasound guided setup. Again, a reasonable way to, or configuration to put patients onto VV ECMO, but again, I would say globally not as common as perhaps those seen in the femoral jugular route or in this dual lumen internal jugular kind of setup. And again, I think for this audience, you're aware that now in 2023, we have reasonably good, high quality evidence to suggest a benefit of VV ECMO in patients with severe ARDS. So just to summarize quickly, on the left, you can see our most recent and modern trial, the Olia Trial, which was led by Alain Combe and colleagues at La Pitié Hospital in France. We were fortunate to be a study site here at the Toronto General Hospital for this trial. And this trial tried to pick up on the sort of shortcomings or challenges that we saw in the Caesar trial, where there was a benefit in 6-month survival without disability in that trial, which was the primary outcome. But of course, all the patients had to be transferred to a single center in the UK to receive ECMO. And of those 90 patients in the Caesar trial that got transported to Leicester for ECMO in the trial, 25% of them never received ECMO because they got better with, increasing sedation, changing the vent settings, adding some inhaled pulmonary vasodilators. So it really wasn't a trial of ECMO versus no ECMO. It was more a trial of transporting sick patients to an advanced referral center that could provide ECMO. And so Eolia tried to fix some of those challenges that skeptics were picking up on, and really to protocolize all aspects of care, deliver ECMO in expert centers, and compare it to, again, the best conventional mechanical ventilation strategy in the control group. The plan was originally to enroll 331 patients in an adaptive design, but the trial was stopped early after 249 patients were enrolled due to, at a fourth interim analysis, due to futility to show a statistically significant result. This was in the trial planning, a pre-planned stopping rule, because if we had continued to enroll patients to 331, we were unlikely to show a p-value less than 5 for a significant difference in the primary outcome. That being said, what you could see here is the Kaplan-Meier curves, and there was an 11% absolute risk difference in favor of ECMO, okay? Although that, again, didn't quite reach statistical significance. No time today to speak about the wisdom of using a dichotomous p-value to decide whether we should or shouldn't do things. That's a whole talk in and of itself. But to say that, the primary outcome was in favor of ECMO. Most secondary outcomes in this trial were also in favor of ECMO. Even stroke was less in the ECMO group, although bleeding complications were, as you might expect, increased in the ECMO group. Accompanying this article in the New England Journal were 2 editorials, and one by Jeff Drazen, who's the editor-in-chief at the time of the New England Journal, who basically summarized that this is probably the most positive negative trial you could get. So although the p-value wasn't significant, all the outcomes seem to move in the same direction and to be in favor of ECMO. And sort of suggests that when your primary outcome fails, then you try to look for other supporting evidence. And on the right, I've sort of summarized that. And following the Eolia trial, we now have reasonable secondary analyses that all support the use of ECMO, including a Bayesian reanalysis led by my colleague Ewan Gallagher that was published in JAMA that showed a very high posterior probability, upwards of 90% and above, that under almost any circumstance, there is likely to be a benefit of VV ECMO for patients with severe ARDS. We have a traditional study level meta-analysis, again, led by my colleague Lavina Munshi, that showed a statistically significant improvement in mortality with VV ECMO. We have individual patient data meta-analyses, and now 3 network meta-analyses that all show that VV ECMO has a significant advantage in terms of mortality for patients with severe ARDS. So you'll see some of this now codified in updated guidelines for ARDS that are coming out from the ATS that we'll have out hopefully later this fall, as well as forthcoming guidelines from the European Society of Intensive Care Medicine that will also have a new recommendation for ECMO that should be out shortly. So then when we think about COVID, then we have this, this large, as I mentioned, large group of patients who showed up at the hospital with relatively homogeneous cause of acute respiratory failure. And at the outset of the pandemic, we had a lot of back and forth, and maybe not unsurprisingly, because it was a new virus, a new challenge that we hadn't seen before, and a lot of unknowns. And there was a lot of arguments back and forth of whether COVID-19 as a viral pneumonia was causing traditional, if you will, ARDS or not. So we have these very provoking editorials or commentaries by thought leaders like Luciano Gannoni, suggesting that COVID-19 pneumonia really wasn't our usual ARDS, as compared to eventually, as more and more data accrued over the course of the pandemic, you had articles like this at the bottom where you had larger and larger observational cohort studies across jurisdictions, suggesting that, as this title says, clinical features, ventilatory management, and outcomes are basically similar to other causes of ARDS. And I would say it's important to understand this in the setting of the pandemic because, again, there were a lot of unknowns, but this also led to a lot of discussions about then whether we should be using the same approach and the same interventions that we use in regular ARDS in patients who have severe COVID-19, and also brought to light the question of then, if you do that, should we expect similar results? Because maybe it isn't really ARDS like from non-COVID-19 causes. But again, I think the key to many of these things is data. And we summarized after a while, because of this back and forth about the differences in COVID-19 versus non-COVID-19, the possibility of this L and H phenotype. I'm sure this is all bringing back some memories and PTSD for everybody who's listening in the audience, but all this conflict in the literature about what to do early intubation before versus delayed intubation, and also some questions that we'll discuss about ECMO itself. But basically, again, as data started to accrue from jurisdictions around the world, beginning in Wuhan and then moving towards Italy that got affected, then at the start, the Western United States, and then certainly you in New York City having a huge impact from the pandemic. What we started to see was that indeed, when you look at many factors like the kind of respiratory support, the PF ratio, the compliance, how these patients were ventilated, what they required, it pretty much looked just like ARDS of any other cause. And what I didn't include here was a subsequent comparison to patients in a very global epidemiologic study of ARDS, the LungSafe study. And again, when you look at LungSafe, all of these parameters are pretty much the same on average as those in LungSafe, which of course took place years before the pandemic and sampled 500 ICUs across 50 countries in the world. And so very similar results. So all the data suggested that ARDS was from COVID-19 was basically like ARDS. And of course, again, as we start to get more histopathology and autopsy studies, again, the autopsies also pretty much showed that what you had was diffuse alveolar damage and ARDS, even from a pathological point of view. Now, that being said, there were some striking differences in the sense that we do know that COVID-19 in and of itself also induced a lot of challenges with the coagulation system. There might have been more microvascular thrombosis, which again is also part of DAD, but certainly maybe more with COVID-19, and maybe disruptions due to endotheliopathy and other activation of neovascularization. So those changes are in addition, but underlying that, there was still the fundamental presence of diffuse alveolar damage at least the histopathological level. And then clinically speaking, as we're talking here, the otherwise the characteristics of these patients was pretty much in line with ARDS of non-COVID-19 causes. And then finally, this led to all these sorts of Delphi conversations and consensus conferences. And this is just to say that in the UK, they basically concluded that the expert panel found no reason to deviate from the evidence-based support strategies for managing ARDS that were outlined in recent guidelines, and that we should basically be treating COVID-19 ARDS just like ARDS. So as in terms of the background for our discussion, then this is the idea that we should conceive that patients who meet criteria with COVID-19 ARDS for VV ECMO, just like in the non-COVID-19 ARDS populations, that we should proceed to put those patients on ECMO like we would have even before the pandemic, and certainly now following the bulk of the pandemic. So what were the important lessons that we learned? Well, here's some of those sort of situations where early data or the paucity of data as the pandemic evolved led to this idea, or fueled the idea, that COVID-19 related ARDS was different than ARDS of non-COVID origin. So this is early data from China, many of these from studies out of Wuhan. And what you could see here, maybe basically, if I could summarize, is if you look at this column on the far right here, that basically in these cohort studies that included upwards of 200 patients that received 200 COVID-19 patients, but just a few that received ECMO, that the survival in these patients was dismal. Okay, it's about 0%, zero in most of them, maybe one survivor in this series where 6 patients received ECMO. So this sort of early data out of Wuhan, and then certainly as the pandemic unfolded across the world where health systems were taxed, human health resources were sapped, the idea of putting patients onto ECMO, if it was going to be futile and the results were going to be extremely poor, led to calls for moratoriums on ECMO use in COVID-19. Now, of course, the challenge here is that that's exactly some of the same factors that likely contributed to the poor outcomes in these sorts of observational studies out of China, was that they waited longer than our usual inclusion criteria. ECMO was applied late. Patients were already in multi-organ failure. And again, there likely was an important contribution from the fact that their healthcare teams were overwhelmed, and the management and support of some of these complex patients was very challenging. And so we needed, like we have in other similar pandemics like H1N1 in 2009 and the original SARS outbreak in 2003, is that we needed rapidly to get more data that we felt would be more representative or better representation of what ECMO could do in terms of outcomes for these kinds of patients. So fortunately, we started to get some of these data and larger data sources from other jurisdictions around the world. So as ECMO swept across Europe and made its way to France, we have these data from, again, La Pitié, which is one of the largest adult ECMO centers in Europe, if not the world. And this a report from Matthew Schmidt in Lancet Respiratory Medicine, again, showing that in these 83 patients that were put onto ECMO, this is a stacked bar plot, but basically I want to focus on the fact that the 28-day mortality was about 35% in those patients who received ECMO. And if you look back traditionally, that's about, again, representing a survival of about 65%, which again is pretty consistent with our previous observational reports from ELSO and other data sources suggesting that when you have ARDS of non-COVID origin, that survival rates are in about the 60-65% range. If anything, it's probably just slightly lower than if you look specifically at viral pneumonia in the ELSO registry, which has a slightly higher survival advantage, but pretty much in the same ballpark, and certainly very different from the 0% or 1% survival rates that we were seeing in the early data out of Wuhan. So again, this data from Paris suggesting that if you apply the same inclusion criteria that we had previously, our evidence-based guidelines, that you could get results that are very similar for COVID-19 patients as for non-COVID-19 patients. And then again, this was taken up by the Extracorporeal Life Support Organization and under the leadership of Ryan Barbaro, who was the registry chair at the time, really was the idea then to use this existing data structure in the world where many large ECMO centers were already voluntarily reporting data to ELSO, was to add quickly a data module to collect data specifically about COVID-19 and then to understand what was going on around the world. Again, here's another stacked bar plot, but maybe focus on this cumulative mortality graph on the right here, where when we looked originally just after wave 1, where 1,000 patients were reported to the registry of having VV ECMO for COVID-19, you can again see that the cumulative mortality was about 35-36%. Again, very consistent when you look at data from the ELSO registry prior to COVID-19 for the survival overall of VV ECMO for severe ARDS, but again, perhaps slightly lower than that if you were to look specifically at viral pneumonia. So again, more data that suggested that if you apply the evidence-based criteria for the use of ECMO in these patients, you applied it early, didn't wait until it was patients were in multi-organ failure and the maybe more non-beneficial application, that you could get results that were similar to ARDS from other causes. Oops, sorry. Similar factors seem to be at play in these patients that we had seen pre-COVID. So very consistent sort of signal. Here again is data not just from La Pitié in Paris, but sort of from the greater Paris area, a number of ECMO centers there. And what you can see in these Kaplan-Meier curves on the left is that very similar prognostic factors that we had seen before were confirmed in ECMO. So pretty not surprisingly, you could see in panel C that the older you were, so age over 57 being red, age under 48 being blue, the older the patients were at ECMO initiation, the worse the outcome. The longer you waited, and again, this sort of maybe puts the Wuhan data in context, the longer you waited between intubation and ECMO, the worse the outcome. So blue was less than 3 days between intubation and ECMO, and red was greater than 6 days. So sort of a steady dose response increase in mortality as you waited. Caseload, again, was very important. And this was key again in the pandemic because many maybe relatively more inexperienced centers and even some centers that were de novo created in the pandemic to meet the increasing need for ECMO. Unfortunately, we know that case volume is a very important modifier. And so here you can see that centers that are doing 30 or more cases per year prior to ECMO had a much better survival rate than those that are doing 30 or less cases. So again, this may have impacted some of the ECMO results moving forward because some relatively inexperienced centers and new centers had come up and their outcomes were a bit different. In the Paris area, as well as in many other jurisdictions, there's a lot of hub and spoke mobile ECMO transfers. And this was just to show that actually mobile ECMO transfers didn't have a significant effect on outcomes, so that therefore mobile or transferred patients were doing just as well as those that showed up at an ECMO capable hospital in this health system. And then finally, this is just to hammer home the idea that centers that adopted ECMO later, so again, relatively inexperienced or new centers that sort of came online, their mortality was actually quite a bit higher than those that had been doing ECMO prior to the pandemic. So again, if you just focus on the blue bars, the blue part of each curve, which represents mortality, you can see mortality again here about in the 30%, 35% range for those centers that were already doing ECMO prior to the pandemic or May 1st, 2020, versus those that adopted late and started after the onset of the pandemic. Their mortality in this blue bar here was above 50%. So a clear difference in centers that were adopting late. And again, reinforcing this idea that, ECMO is a team sport and it's involves a huge interprofessional team. And certainly a lot of that experience and expertise gets developed over time as the team manages more and more cases, and that case volume or experience is a very important modifier of outcome amongst patients receiving ECMO. Again, so this is a meta-analysis led by Colin Ramanathan in Singapore that basically summarized that again. The idea, the key is that data is king. And as data accrued over the pandemic, then rather than 0% mortality, which was sort of more of an outlier, you could see that on average in the systematic review, mortality, when you pool it across a number of observational studies, really representing jurisdictions all over the world, mortality was again in the mid 30% range, very consistent with previous reports of mortality of ECMO in non-COVID-19 situations. One of the challenges, though, of course, is that some of these studies can be very confounded. Observational studies or case series really provide highly selected populations where physicians or health teams have already selected the best patients, if you will, to receive ECMO therapy. And so maybe we get very biased answers. So we try to get at the answers a little bit better, short of a randomized controlled trial, by using things like exploiting a natural experiment. This is very interesting data from Vanderbilt, led by Whitney Gannon, showing that when there were hospitals in the United States who could provide ECMO, but they were so full or had no capacity to provide ECMO, the number of patients who died with similar characteristics was extremely high compared to those hospitals that continued to have ongoing capacity for ECMO. And the adjusted hazard ratio here was 23%. So a very significant difference that when ECMO capacity wasn't available, patients were dying, sort of suggesting, again, and exploiting this natural history situation, that ECMO was an important influencer of mortality and could lead to better outcomes in patients if you needed it and you could get it. Similarly, in a study in the UK, where again, they have a very national system and only 5 specialist centers in the UK that have been commissioned to provide adult ECMO, looking at 2 such centers with 111 hospitals referring to them, when they looked at the 243 patients that received ECMO and matching them using a propensity score or a gen matching technique, they saw that the reduction in mortality was quite substantial. So very similar patients with similar severity of illness who received ECMO compared to those that were of similar severity but didn't receive ECMO, the odds of death was reduced by more than half, with an absolute reduction in death of nearly 18%. So very substantial reduction. But again, the best way to answer this question of what is the efficacy of ECMO in COVID-19 would be to perform a randomized controlled trial. Now, again, given all the things that we've experienced, and I'm sure you guys experienced as well, is that the challenge of conducting a trial in peacetime for ECMO is already really hard. CSER took nearly 10 years to complete. Olia took nearly 6 years to complete. In the throes of a pandemic, it's really unable to organize, although there was some discussion by NIH, NHLBI, and NIA and NIAID about doing such a trial. It never sort of left the ground. So what we compromise on is this idea, and here's a nice perspective on that from Miguel Hernan, who's an epidemiologist at Harvard, who's really pioneered these methods of using observational data to emulate a randomized controlled trial when you can't perform that randomized trial. So the idea there is that you design this target trial. This is what I would target to do if I had the resources, time, and patience to do an RCT. And I emulate that trial using observational data as a compromise when a true RCT isn't available. And also a good method when you know that an RCT will never come. So prior to this perspective, Miguel Hernan had published in the New England Journal a very large study, emulated target trial using healthcare data in Israel, comparing Pfizer vaccination to Moderna vaccination. Now, in the real world, we weren't going to get a head-to-head RCT on that, but using claims data from Israel, and it's over 1 million patients who received vaccination, he was able to emulate a target trial and evaluate the efficacy of those two different vaccination types because we weren't going to get an RCT. So the point here is that we were able to do that along with other groups during the pandemic to really get at the causal effect of ECMO therapy in patients. This is one from the United States led by Shaifi and colleagues. And again, Miguel Hernan was an author on this, looking at emulated target trial of VV ECMO in COVID-19 patients. And basically what I want you to focus on is this forest plot on the left, which basically showed in their primary analysis for anyone whose PF ratio was less than 100 with COVID, that if they got ECMO, that result favored ECMO with an adjusted hazard ratio of 55%, so a 45% reduction in the hazard of death. And that seemed to work across a number of sensitivity analyses, depending on how you defined the etiology of infection, how sure we were about their COVID status, like sort of a PCR confirmed rather than just clinically suspected. And interestingly, when you look at more stringent thresholds, like classically we did in Olia, which is the PF ratio less than 80, get very similar results. And probably most interestingly, if you look at even less hypoxemic patients, so traditionally we wouldn't consider patients who had a PF ratio up to 150 for ECMO, but in this study, clearly some of these patients were getting ECMO up to that level of hypoxemia, that these patients also derived a very similar benefit. So again, the idea here that a very consistent result across a number of analyses suggesting a very profound and statistically significant benefit for ECMO in these patients. Our friends in Paris, again, also undertook a emulated target trial looking at the data from France. They used a slightly different methodology here. I only include this diagram here to show you that it's a very complex sort of analysis, and where it's basically emulating sequential trials on every day, because every day new groups of patients may become eligible for ECMO because their hypoxemia worsened or their hypercapnia worsened or that sort of thing. But basically, again, just focus on panel B here, is that what they found was that there was a very large separation, statistically significant separation, for the use of VV ECMO in high volume centers meeting the criteria as compared to low volume centers using the same criteria. So again, suggesting that in the right hands and using evidence-based indications for VV ECMO in patients with COVID-19, ECMO was very effective. And then finally, our own group, led by one of my graduate students, Martin Erner, we used data from John Fraser's COVID-19 Critical Care Consortium, which was a global consortium collecting data about the use of ECMO and mechanical ventilation in COVID-19 patients. We emulated a target trial that again showed a very similar risk difference, 7% reduction in mortality, which is very close to the 11% reduction in mortality that we saw in Olia. There was also a significant increase in the probability of leaving the hospital alive. And again, what we saw was that the older you were, the worse it was. The earlier you deployed ECMO, the better. And again, it was most effective for patients with a PF ratio less than 80, which would be the evidence-based cutoff. But we did see ongoing effect up to a PF ratio of up to 120. And again, it was most effective in those in which we can reduce the intensity of mechanical ventilation. So those who started with the driving pressure above 15 had the greatest benefit. And it was robust in a number of sensitivity analyses, so suggesting a good effect. And then finally, we could combine a lot of these data. This was a study led by Shannon Fernando and Alex Tran out of Ottawa, looking at the existing literature. And we could see that a lot of prognostic factors, again, very consistent with our previous knowledge before COVID, suggest that in these patients, older age, male sex, underlying chronic lung disease were important prognostic factors that led to worse outcomes if you got ECMO. If you waited longer, if they had a longer duration of mechanical ventilation prior to ECMO, higher CO2 when ECMO was initiated, perhaps suggesting more dead space in the lung. And again, this idea of higher driving pressure at baseline, they unfortunately did worse. And again, we've seen time and time again, both in the non-pandemic and pandemic situation, that center volume is an important factor because you need experience. And that studies clearly demonstrated that less ECMO experience, doing a caseload of less than 30 cases per year, led to worse outcomes. So reinforcing a lot of the notions that we had evaluated and understood prior to the pandemic with its huge number of patients who had severe ARDS and required ECMO, reinforced and provided a very consistent signal for these sorts of ideas that we had seen prior to the pandemic. I think interestingly in the pandemic, and again in the discussion, I'd love to hear about your experiences in New York, is that again we found that COVID-19 had an important effect on coagulopathy and the coagulation system, maybe the endothelial activation. causing both challenges with bleeding and thrombosis. So we heard it all, like in the early days when there's very little data, again, about these very conflicting experiences across centers. So some centers were calling us and reporting that they were changing oxygenators every few days because they were getting thrombosed, despite increasing the intensity of anticoagulation in their protocols as compared to pre-pandemic. In our center, we had it the other way. We actually had hardly any oxygenator failure or thrombosis. What we had was bleeding. And in our center, we hadn't changed our anticoagulation protocol at all, but we saw a 4-fold increase in the rate of intracranial hemorrhages in our patients, actually sort of prompting us to perhaps consider a decrease in the intensity of anticoagulation in our patients. Again, it's a very heterogeneous reports. Here's just one example from the United States that had a very similar experience to ours, that when they looked at controls, their rate of intracranial hemorrhages was at 6%, which is very close and consistent with the reports from the ELSA registry with intracranial hemorrhage rates on VV ECMO of about 5%. But during COVID-19, they saw their intracranial hemorrhage rates reach 20%. And clearly those with intracranial hemorrhages had increased mortality. So this experience that was published in the literature, again, very much mirrored our experience in Toronto. We didn't have really good understanding, like in terms of when we looked at our patients who had intracranial hemorrhage, again, their heparin levels were therapeutic, platelet levels were not very low. They didn't have a bleeding diathesis underlying any of these things. We ran thromboelastography on many of these patients. We didn't show any overt signs of bleeding problems or whatnot, but clearly something about the virus and an interaction with that host that led to this increased rate of intracranial hemorrhages. Bleeding still seemed in the COVID-19 pandemic, this is a study from Europe, that was more common than thrombosis, and bleeding being more important because very consistently when you look at the fluorescence plot, and again, very consistent at least with my clinical practice, is that although bleeding and thrombosis may occur at relatively similar rates in ECMO patients, bleeding seems to always be the most important one. And bleeding here in this study was more consistently and significantly associated with mortality. If you had thrombosis, of course, that's a problem, but that wasn't significantly associated with mortality. It might lead to problems like circuit changes and oxygenation failure, but didn't seem to lead to an increased risk of mortality. I think the rates of bleeding and thrombosis here and their causes are very similar to that in non-COVID-19 patients. And again, here, at least in Europe, their intracranial hemorrhage rate was pretty much similar to that from the ELSA registry pre-pandemic. But again, there were other centers such as our own that were reporting much higher rates of hemorrhage. I'm not sure if there was a question. I heard somebody.
Yeah, the question. Yeah, hi, Eddie. Just wanted to echo that experience. We also had, pretty much the same experience. I would say we had more bleeding risks, than, thrombosis, and we didn't really have to change our oxygenators that much. I remember one patient who had this intrapulmonary hemorrhage, which kept on going for a very long time, and he was on ECMO like for 3 months with no anticoagulation, and the oxygenator was still okay, right? So yeah, I think ours was pretty similar.
So it's very interesting. And again, I think at some point we would like to do a deeper dive and perhaps an opportunity to collaborate to get a number of centers together to combine their data to understand, because the other thing that's interesting that we also saw heterogeneity, like we had a cluster of patients who would have hemorrhage like very early, like day 3 of ECMO initiation, they would have hemorrhage. But then we also had a few patients who had an intracranial hemorrhage, again, with no other changes at day 50, at day 65. Like it was very strange with no other, again, precipitating, very super therapeutic heparin level or, low platelets or some other new. So it's a very challenging situation, but again, maybe an opportunity for us and a number of centers to collaborate and merge some data to understand if there was some other signal that could be seen as to why some of these patients were having such high levels of intracranial hemorrhage. And then finally, I think, a focus on long-term outcomes, which again, even in the pre-pandemic situation, we still need to get more data on the long-term outcomes of these patients. So this is nice data from my colleague, Carol Hodgson, using a global registry that we're leading called Index and Excel. So in Australia and New Zealand, the registry is called Excel, and globally it's called Index. But anyhow, one of the core outcomes in the patients enrolled in this registry is to look at 6-month outcomes, including disability as measured by the WHO instrument or the HUDAS. And what's interesting here, again, and specifically in looking at ECMO, is that maybe focus on panel A here, is the idea that, again, because we typically select patients for ECMO, whether you're talking VA, VD, or ECPR, maybe you're less selecting, but certainly when we have the opportunity to make an elective decision about ECMO, we typically are choosing patients who have very few comorbidities, have good premorbid functioning, are typically younger, and this sort of thing. So you would expect that the population is relatively healthy with very little disability at baseline, which is what you could see here. And in this, what's called an alluvial plot or a river plot, what you can see here, importantly, is that quite a few patients transition from having no baseline disability or mild baseline disability to having either moderate or severe disability at 6 months. And when you look at VV ECMO, you could see here very similar kinds of results if you look at these sort of, I don't know, red or peach colored lines. And again, sort of just highlighting the point that we need to better understand whether some of this is related to patient selection, or probably, and importantly, some of the things that we expose patients to while they're in the ICU. Again, sedation, bed rest, if they experience delirium, perhaps the use of steroids, neuromuscular blockade, all of these things might have an impact ultimately on the disability or the functional health-related quality of life these patients may experience if they survive and leave the hospital. And so again, to shine a light on the idea that, of course, the whole goal of critical care and a goal of something like ECMO is to get patients to survive, but also to survive well, right? And so the idea here is that we need to dig deeper or drill down more, and these are just a good level look at a high level as to understanding what the epidemiology of disability is in some of these patients, but now provides us the opportunity in future work to understand what modifiable risk factors or exposures our ECMO patients are having that we could, again, intervene on and hopefully lead to better outcomes for patients in the future. So I want to talk maybe more theoretically in the middle and then conclude with some remarks about the future. But the idea that what do we learn from COVID-19 about the use of ECMO in a very large sort of and sort of very compact, if you will, even though it didn't feel compact over 3 years, but sort of time frame about how we should be deploying ECMO for respiratory failure in the future. And I guess the idea here, of course, is that the idea that we now understand that most of what we do for ECMO could actually lead to very profound, if you will, lung replacement therapy. So if we can get patients breathing less on ECMO, maybe we could have less ventilator-induced lung injury. Of course, if we completely stop, or replace the function of the injured lung, maybe we could have no VILI. And so this idea is not a new one, I would say. It's actually old and really from the origins of ECMO itself. Just first is remember that ECMO is not a very new technology, even though it seems like we've just been using it more and more in the last 10, 15 years in adults. But it came to the market in the 60s and 70s with the advent of cardiopulmonary bypass. And here's an article from the 70s from some of those pioneers, Ted Colombo from NIH and Luciano Gattinoni, who was a fellow at the time in Dr. Colombo's lab at Bethesda. But they were already studying the use of extracorporeal support and CO2 removal in large animal models because they thought this could revolutionize the care of patients with respiratory failure. And so what you could see in this article from the 70s using a large animal model here, maybe a sheep or something like that got tracheostomized, was the idea you could manage them completely with extracorporeal support. And they said at the time, like 50 years ago, even then, we don't even need pressure, or maybe we don't even need mechanical ventilation, right? We can actually use apneic oxygenation, so just apply oxygen to the tracheostomy, and CO2 removal or extracorporeal support could really change the way that we support these patients, especially in difficult cases. And again, we've seen that in the H1N1 pandemic. We've now seen that in COVID-19. We've seen it in other patients that we support with ARDS. But the idea is that maybe we could push the concept further in that by replacing or providing an alternative to breathing, we could really change some of those outcomes, both in the short term and long term for some of these patients, because maybe we wouldn't need to give some of those things that are causing harm for our patients. And again, I highlight this idea because that's one of the main reasons we think ECMO is beneficial. So we saw the top line results from the Olia, but when you dig into the supplement, although we all remember deploying ECMO, and again, COVID fresh in our minds, deploying COVID in that patient who was dying of hypoxemia with a SAT of 50 and a PF ratio of 30, that we thought that was the reversing life-threatening hypoxemia is the main benefit of ECMO. But when you look, actually, the group that was most hypoxemic, PF ratio less than 66, their mortality wasn't very different across control and ECMO groups, but the biggest change in mortality was amongst those who were less hypoxemic. So nearly 50% mortality in the control group, but 27% mortality in the ECMO group. And again, one of the main benefits we think of ECMO is not so much fixing hypoxemia, but because we replace the function of the native lung, you could greatly reduce the intensity of mechanical ventilation, and you could put the lung at rest. And when the lung is at rest, then there's less ventilator-induced lung injury. Less ventilator-induced lung injury leads to less multi-organ failure and death. This is the rationale, obviously, behind lung protective ventilation, which is it takes us only so far. But here, because we can go beyond traditional lung protective ventilation, we're hypothesizing that's where we're getting the majority of extra benefits. And again, to reinforce that hypothesis is the idea again here. If you look at patients who had low driving pressure, less than 16 centimeters of water at baseline, really no difference in mortality. But the biggest difference in mortality between ECMO and control groups were those who had high or injurious levels of driving pressure at the outset, 51% mortality in the control group and down to 39% in the ECMO group. Again, we think we're hypothesized because we had a dramatic reduction in driving pressure in those patients who were receiving injurious levels of mechanical ventilation. Okay, so good idea, strong physiological rationale as usual. And then what happens? You try to test it in an RCT and it sort of goes up in your face. So our colleagues in the UK, James McNamee and Danny McCauley, took this data and a whole bunch of other preclinical data, small observational data, suggesting again that this is a good idea, that if we can use an extracorporeal support system to reduce the intensity of mechanical ventilation, that's probably going to lead to benefits for patients and hopefully achieve a difference in patient-important outcomes like mortality. So they designed this trial, the REST trial, which sought to use not full-blown VV ECMO, but again, because the idea here was mainly not to provide oxygenation for patients with severe ARDS, but it was more to facilitate CO2 removal so that we could reduce driving pressure, tidal volume, reduce the intensity of mechanical ventilation, reduce VILI, see if that improved outcomes. They set out to design a study of 1,100 patients randomized to CO2 removal using a hemolung system and reducing tidal volume to 4 mils per kilo versus best conventional mechanical ventilation targeting low tidal volumes. The study you could see here was stopped after 405 patients were enrolled, and here's the Kaplan-Meier curve. You could see that in the yellow line, which is the CO2 removal group, that not only was CO2 removal not good for you, it was bad. Okay, it caused harm. So the mortality is higher in the CO2 removal group than ventilation alone. And here you can see that mortality was 42% in the CO2 removal group and 40% in the ventilation group. Ventilator-free days were also less in the ECOR group, and a whole host of complications, bleeding, and most importantly, intracranial hemorrhages was more common in the CO2 removal group. And that's despite them reaching their physiological goals. So they did by day 2 reduce tidal volume in the ECOR group to 4 mils per kilo, and that led to a concomitant reduction in driving pressure of about 2 centimeters of water. So what did this trial tell us? It told us that deploying this system and this strategy in these patients certainly didn't lead to a benefit and led to an excess of harm, despite this very modest reduction in tidal volume and driving pressure. But the idea here is that there's likely a good degree of heterogeneity of treatment effect, and the hope is to not throw out the baby with the bathwater. Okay, so remember that this is not so much an evaluation of ECOR or extracorporeal support as a strategy in general. It's that at least that protocol using that device with a very modest reduction in tidal volume and driving pressure led to an excess of harm versus, the trade-off of any benefit that might have occurred from that very modest reduction. And again, part of the challenge is that this was a very heterogeneous group of patients. They enrolled acute hypoxemic respiratory failure patients, so mostly anybody who had a PF ratio less than 300, and so a very heterogeneous group of patients. So one of our graduate students, Jose Diante and Ewan Gallagher, looked back at the REST results and again saw that there was heterogeneity of treatment effects. So patients who had a higher ventilatory ratio over about 3, so maybe more dead space, benefited more from ECOR, didn't seem to modify at all by respiratory system elastance or compliance, and those who had less hypoxemia, so PF ratio over 115, did better. So again, this idea, these results provide us with extra ammunition for a future study looking at such a strategy, perhaps with a device that will lead to less bleeding complications, maybe a better understanding of how to anticoagulate these patients to avoid bleeding complications, and enriching on patients that we think have the highest probability of benefit could lead to a better trial and hopefully some better answers about that in the future. The other thing to say is that, again, we probably need a bigger reduction in driving pressure and tidal volume to see a result. We have physiologic work from our group showing that when you increase driving pressure from 10 to 20 centimeters of water, that you get a very profound and linear increase in plasma biomarkers as a surrogate for villi. And even though you might be ventilating with very small tidal volumes, as we did in this randomized crossover study of 2.5 mils per kilo, you could still see an increase in biomarkers if you increase driving pressure. So the logical idea here is to reduce driving pressure to as low as possible. And of course, if you thought in a very idealistic sense that if we had something like ECMO where we could completely replace breathing, this whole idea of the alternative to breathing, that if you reduce driving pressure to zero using something like CPAP or extubated the patient, you could have even further reductions in villi. We haven't done that in humans, but in experimental models like in mice, that's exactly what they've shown. And again, the ironic thing is that this idea is the original idea from the 70s that Luciano and others were publishing on then, is that if you went to a model of near apneic oxygenation and try to support the lung with extracorporeal support, you could get good results. I just want you to focus on the picture here on the right, because the picture is worth 1,000 words. If you look at the histopathology of the lung in sham animals who are just getting CO2 removal and no ventilation, there's very little inflammation and very little damage. The near apneic oxygenation group is most closely similar to the sham group, and certainly much better in terms of inflammation and injury as compared to the conventional mechanical ventilation group, and maybe not surprisingly, of course, the non-protective ventilation group. So again, the idea that pushing the boundaries further could lead to greater benefits. That's what we think. So we're going to test this hypothesis in a CIHR or Canadian funded trial called the Ultimate Trial, where we're going to use mid-flow ECMO on patients with moderate ARDS to see if reducing driving pressure through tidal volume in these patients would be beneficial. We're collecting a lot of data about safety and feasibility in this study, especially about the feasibility of conducting ultimately a larger phase 3 trial, as long as a bunch of physiological and mechanistic endpoints. So hopefully more results on that for you in the future. And then finally, I want to finish with the idea that what we learned from COVID-19 is that maybe we need to move beyond just protecting the lungs, because ARDS and COVID-19, it's more than just a lung problem. This is a great commentary from Nate Brummel a few years ago, sort of called Willie Sutton and the Future of ARDS Research. And of course, Willie Sutton was the bank robber who said, when he asked why he robs banks, because that's where the money is. That's how we've approached ARDS, right? It's a clinical syndrome of respiratory failure, and we viewed it through the lens of a pulmonary syndrome. Therefore, because it's a lung problem, we focused on interventions that are directed at the lung: mechanical ventilation, optimizing gas exchange, oxygenation. And these patients were clearly suffering from respiratory failure. That's the main problem. But now we've seen, of course, is that ARDS is actually a systemic problem. The major driver of mortality in ARDS, as well as the morbidity, is not the lung, it's multi-organ failure and sepsis. Remember that 90% of patients with ARDS die of multi-organ failure and sepsis. Only 10% die of refractory hypoxemia. And we now know from post-intensive care syndrome, long COVID, whatever you want to call it, that these patients leave with morbidity that isn't really focused on the lungs. If anything, the lung usually has the least amount of morbidity. Many of these patients don't have or require supplemental oxygen. They have maybe slightly deranged PFTs, but their morbidity is functional, right? They're weak. They don't return to work. They've lost 20% of their lean muscle mass. 30% of them have anxiety, depression, PTSD. There's caregiver burden. There's a huge non-pulmonary problem. So now we know that this is a systemic syndrome that's not limited to the thorax. So we need to move beyond just protecting the lungs, because that actually usually isn't the biggest problem. We need to think about the nervous system, the heart, the kidneys, the muscles, and all these sorts of things. So we need to move beyond thinking about the lungs. So again, it's the idea that we shift the paradigm, and extracorporeal support could help us to do that, away from just thinking about short-term outcomes like mortality and limiting villi, but maybe we can maximize extracorporeal support. So not only can we reduce villi, but maybe if in some of these patients we could stop mechanical ventilation and all the stuff that we give with mechanical ventilation that leads to harm in our patients: oversedation, paralysis, bed rest, and immobility. These things lead to morbidity. And again, if we can use extracorporeal support to facilitate a reduction in these things, we can get the awake, calm, cooperative, mobile patient. Maybe not only will we have better mortality, but maybe we can have better morbidity for these patients. This is a hypothesis, of course, it's nothing that's been tested, but we're very intrigued by this report. I'm not sure if you saw it in the midst of the pandemic from a group in Chicago, showing that they tried to do just that. So in COVID patients who required ECMO, And in these patients, they cannulated them through the venopulmonary route using a Protect Duo cannula. They actually, rather than trying to get them off ECMO as quickly as possible, they kept their patients on ECMO so that they could desedate them and get them awake, get them off the ventilator, sometimes through a tracheostomy, and then facilitate early rehabilitation. And through stabilized gas exchange, they thought some effects of RV protection from this route of cannulation, they actually achieved that in the vast majority of patients. ECMO duration, as a result, was actually longer than usual because they were trying to keep them on ECMO to maximize these goals rather than necessarily getting them off ECMO or for lung protections per se. Mortality is actually extremely low in this population, in the 20% range. So we're very intrigued at this use of ECMO as a way to, again, move beyond the lungs and think about the patients as a whole. Now, I don't know about you guys, but again, and Sam, maybe you have comments on this, I didn't see many COVID-19 patients like this during the pandemic. Like if I tried to wake up a COVID-19 patient on ECMO during the pandemic, it was a hot mess. They were delirious, they were very tachypnic, respiratory drive was very difficult to manage, they would desaturate. So we didn't see a lot of patients like this. Again, that being said, we didn't use this configuration specifically in many COVID-19 patients, and whether that is an essential part of the formula is unclear. But just to say that these results are extremely intriguing as a proof of concept for that hypothesis that we might think about the patient more holistically and maximize ECMO use to benefit the patient more holistically than just thinking about ECMO as a strategy to protect the lungs and focus on lung protection. Again, there's some rationale for this, as I've already presented to you, because in our emulated target trials, we showed that the mortality benefit wasn't just limited to those with a PF ratio less than 80, which was tested in Eolia, but even up to about 120 or 150, we saw some benefit. So targeting that group of patients, again, who more likely could wake up and not be in a hot mess, which might be moderate ARDS, that's where I think the money is going to be. There's always going to be trade-offs. And here again, we're talking about there's potential trade-offs between mortality and morbidity. And again, in 2023, the sort of rationale behind testing something like this is the idea that, do we now think that complications related to ECMO, anticoagulation, platelet dysfunction, being on a circuit, and that sort of thing, are actually perhaps less than the complications that are associated with being on mechanical ventilation? Ventilator-induced lung injury, ventilator-associated complications like VAP, the sedation, the paralysis, the bed rest, and all those things that go with that. Where do we think the trade-offs are? Of course, we need to test that in a clinical trial. And again, the idea of moving beyond strict lung protection is maybe that we were trading off maybe some more chronic lung dysfunction, but perhaps, again, by reducing some of those other exposures we're providing these patients, we might have better physical and mental health complications. Again, these are all conjectures at this point, something that we need to test in a trial. Some pause about getting these patients up and moving because, again, our colleagues in Australia, Carol Hodgson, recently published a team trial showing that not only did early mobilization in these patients, some of whom received ECMO, didn't have a significant impact on days alive and out of hospital at day 180, but there were more adverse events due to mobilization. So we've got to be sure that we have a strict and careful protocol and experienced therapists getting these patients up and moving or assessing them for the readiness for rehabilitation, because there could be more adverse events. But again, I think Carol would be the first to tell us that we need to interpret this study in the proper context, right? We expect more complications during early mobilization, right? In a patient, if you compare a person who's getting up and moving versus a patient leaving in bed, of course, there's going to be more work of breathing, desaturation, inadvertent NG tube dislodgement, inadvertent extubation, that sort of thing. It's going to happen more versus a patient where you're just not doing anything to them in bed, right? So we expect that there's going to be some more complications, but of course, the impact of those complications is going to be important, and strategies to mitigate those complications as you get them up and moving will be key. So finally, the idea here is that we want to change the idea of how we label the use of ECMO to what is our intent. And our intent here is that in the right patients, perhaps in the moderate ARDS patients, that we're not only using it to facilitate a reduction in mechanical ventilation intensity, but maybe with the right amount of support, we could also get these patients a bit more awake, off the ventilator, and doing some rehabilitation. So we're actually going to study this based on that study out of Chicago, and with support from LivaNova, is to put patients with moderate ARDS onto the venopulmonary route of support. We're going to see the safety and feasibility of this strategy, and also to get some mechanistic data on how much RV protection might be occurring in these patients, and really, again, to assess the feasibility of testing this kind of strategy in a larger phase 3 trial in the future. Okay, the last things, I think I'm running short on time. I'm just going to quickly say, because I want to get to questions, is to say that one of the other silver linings of the pandemic is the idea that platform trials is the way to make efficient the answering of all these questions that we have. So we saw the power of things like recovery, remap cap at trying to get important and quick answers to questions about the pandemic that we had no answers to. And so we want to do the same thing for ECMO. We have this platform trial called Practical that's being led by myself and Ewan Gallagher that will include the trials that I mentioned to you, as well as some about invasive mechanical ventilation, steroids, non-invasive helmet ventilation. And so this is the mechanism by which we think we can make these things more efficient in the future. We're going to continue studying observational data. We have a grant in to look at novel causal inference methodology to answer questions that can't be readily answered in RCTs, as well as to look at for heterogeneity of treatment effect. And so I just want to finish with, so it's ECMO, I think, is now well established as a therapy for severe ARDS. It's not really a question of if anymore, but just when and in whom. But again, until we have more data, try to avoid creep, continue to use evidence-based criteria for candidacy. We're very interested in this idea that using ECMO to either reduce VILI further or to shift our thinking to reducing mortality might be better. Again, the pandemic highlighted this, a very important quote from Winston Churchill, that when the facts change, I change my mind. We need to be flexible about what we understand and when we understand it. And as data becomes more available, we need to change our thinking. And again, I think that future research in this space is going to be aided by both observational studies and innovative clinical trial designs like a platform trial. So sorry it took so long, but with that, I'm finished and I'm happy to take any questions that you might have.
Thanks, Eddie. I have a question, and I'm Neha. I'm one of the MICU attendings at Mount Sinai. So my own interests actually start even before the patients in the ICU and on a ventilator, specifically those that we manage on non-invasive ventilation, such as high flow and an IV. And we can see from data that the longer we manage the patients on this therapy, the worse they do once they're intubated and even on ECMO. So where do you see, and then now with the new global definition of ARDS, including these patients, where do you see the future of your trials? Like, do you see non-invasive to ECMO, or especially if the drive is high enough in these patients?
Yeah, so thanks for the question, Neha. It's an excellent question. So much to unpack there. It's agreed. Like, so I think the idea is to intervene earlier, but of course, easy to say, like, not too early and not too late, right? It's the Goldilocks. Like, we want to, and in fact, during the pandemic, there's a bunch of reports exactly as you described, because the increased understanding that it wasn't just about intubation, because it's a clinical decision. Some places might have intubated this person on day 3 and only had 3 days of high flow. And then you would say, oh, that's early in the course, where some places were leaving patients on 10 days of 100% high flow and then deciding to intubate and then saying, oh, now the patient needs ECMO because they're doing very poorly. But it's been 11 days of really high levels of respiratory support. So we had some reports out of France, for instance, doing exactly as you said, was understanding that now high flow or NIV, pretty effective therapy for COVID-19, is that perhaps supporting those patients with either low or high flow ECMO and leaving them unintubated and on those devices was feasible. And again, might be better for a whole host of reasons, especially for the morbidity of the patients. And certainly I'm sure for their well-being and ability to communicate, eat a regular diet and this sort of thing. So I think that strategy is something that we're interested in testing in the future, maybe as an extension of proactive, that could we move even further down the paradigm, not just moderate ARDS by Berlin criteria, which includes invasive mechanically ventilated patients. But again, if this new proposed global definition takes hold, I have some thoughts on that, which we'll have to discuss at a different time, but is including those high flow patients with moderate ARDS. And yeah, I think intervening on those patients is going to be a very interesting study question. And again, that's something that you and your group are interested in. We'd love to collaborate on such a project. And I think what was your next question was about?
I mean, essentially, like, what do you do with your, I don't know if you have, I have a lot of patients who are on high flow and non-invasive for a long time. And then, and we get intubated and now they meet the criteria. What do you guys do with prolonged high flow and an IV when you're making that decision for ECMO or not? Yeah, so I think that's exactly, So I think what we discovered and exactly why we need to make a decision maybe earlier, and maybe that decision occurs on high flow or an IV, to your point, is that what we discovered in the pandemic, and to my previous example, was that day 1 of intubation is very different if it's day 1 after 2 days of high flow, or if it's day 1 after 11 days of high flow, just as an example, right? So what we realized in the pandemic was that exactly that, is that late was late, whether you just counted counting intubation wasn't the right way to go about it, right? 11 days of
high levels of respiratory support, non-invasive or high flow plus intubation is definitely different than 3 days of intubation or something like that. So what we decided actually in the data, at least observational data supported, was that we really need to consider the whole duration of respiratory support. And even in some studies was just the duration of hospitalization or symptoms, right? Severe enough symptoms that you needed hospitalization. So the longer, the worse. So I think I agree with you. I think if what we need to now consider is that, again, because some places would just intubate right away, some places will just keep you on non-invasive respiratory support, that we need to answer this question. And the best way to do that is going to be through a clinical trial or a look at data. But clinically speaking, like at least in my center right now, I wouldn't say that we're thinking a lot about like a bridge to lung transplant, different story, but we're not thinking right now a lot about putting patients onto ECMO right from non-invasive ventilation or high flow. But we might just move to intubate them sooner and then give them a few days before they run out of their window of eligibility. But I don't disagree with you that maybe our learnings from the pandemic should suggest that maybe we need to reevaluate that decision-making process. But at least clinically at the moment, I would say not. Our group is not, say, on day 5 of high flow deciding should we intubate or go for ECMO. I think we probably would intubate and then try to make a quick decision if the patient wasn't thriving to go on to ECMO if they were a candidate.
Yeah. All right. Thanks very much, Eddie. I think this was an excellent talk, and as Neha said, we'll be very happy to collaborate, but I guess, Evan, you want to say, I think we have a meeting after this, right?
Yeah, thank you so much, Dr. Fan. This was amazing. I'm sorry we have to cut you off, but we have our faculty, our critical care meeting right now. So we look forward to hopefully having you back sometime in the future, hopefully in person. And we'll speak to you soon. Thank you guys so much.
Yeah, thanks so much. Sorry I didn't leave time. Happy to answer questions by email if anybody has them.
Okay,
Thanks.
all right, Eddie, thanks.